Anju for her talk on what to do when an infant presents with nystagmus.
Good afternoon, one and all. I thank KSOS and Elizabeth ma'am for this opportunity. My talk is what to do when an infant presents with nystagmus. And we all know no need of an introduction to what is nystagmus, to and fro eye movements with slow drifts and corrective saccades. CMA's group has classified nystagmus in infants as infantile nystagmus syndrome, fusion maldevelopment nystagmus syndrome, and spasmus nutans. Infantile nystagmus syndrome it was earlier classified as sensory and motor nystagmus. It appears by 2 to 3 months of age. It's binocular, conjugate, horizontal, pendular to jerk nystagmus. Decreases classically with sleep, convergence, and head posture, and increases with fixation. It is usually associated with eye abnormalities like albinism, aniridia, and congenital cataract or glaucoma. Fusion maldevelopment nystagmus syndrome includes the nystagmus which was earlier classified as latent and manifest latent nystagmus. It's also a jerk nystagmus. Its onset or increase with monocular occlusion. It's a horizontal and conjugate, and usually associated with infantile ET and DVD. The direction is to the fixing eye, and so there's a reversal of direction with the fixation of the eye, and therefore it can mimic two nulls, and classically binocular vision is better than monocular vision. Another type is spasmus nutans. It's a triad of nystagmus, head nodding, and abnormal head posture. Although the child is noticed because of head nodding, the classical and the earliest symptom and the most constant finding is a shimmering high-frequency nystagmus. And it is asymmetric, disconjugate, and good prognosis because it disappears by 3 years of age. And some optic pathway gliomas can mimic SNS, and therefore neuroimaging is a must. Nystagmus blockade syndrome, as the name suggests, it's blocked by the fixing eye in adduction, and as the eye abducts, there's appearance of nystagmus, and has an appearance of pseudoabducens palsy, and the face is turned to the fixing eye. Periodic alternating nystagmus, it's a jerk nystagmus which reverses direction periodically, and periodicity varies from 4 to 8 minutes depending on whether it's a congenital or acquired. The jerk starts in one direction, then it slows down, comes to a point where there is null or no nystagmus, and then it beats to the next direction. So it again has two nulls and alternating head postures. And therefore, every jerk nystagmus you must observe for at least 5 to 10 minutes to look for changes in amplitude or direction of nystagmus. Child is classically brought by the mother with history of wiggly eyes, or the head or the eye being turned in one direction. And the mother may say the child is not able to see beyond a certain distance. Classically, the age is before 6 months. And acquired cases may have symptoms of oscillopsia and neurological signs and symptoms. Visual acuity assessment, certain points to be remembered. It has to be tested both binocularly and monocularly, and near and distance as well. And visual acuity in different cases should be tested. And visual acuity in null position. And if there is a latent component, you have to fog, not occlude the untested eye. And you have to look for whether there's any visual acuity improvement in convergence with base out prisms and minus lenses. And you have a longer assessment time for these patients because most of these children may not manifest their head posture at the onset, and you have to give visually demanding tasks. The stress brings out the nystagmus and the head posture, and you may see variable visual acuity in visits. You have to look what is the type of nystagmus, whether there's a head posture, whether it's vertical or horizontal, and whether it's conjugate or not, whether it's associated with strabismus, whether there's dampening on convergence, and what is the effect of monocular occlusion. Here you can see a child on convergence, there's no nystagmus, but as you occlude one eye, you can see a beat nystagmus, jerk nystagmus to the direction of the fixing eye. You have to measure the phase turn Simply using a protractor and scale or a goniometer. Examination of the anterior segment and posterior segment may reveal other changes like an iridia or other congenital cataract or glaucoma, and you can see when an albinotic fundus. Investigations, other investigations include electronystagmogram, VEP, ERG, and OCT. Eye movement recordings are important because visual acuity here does not depend on the intensity of nystagmus, but on fovation time and eye velocity, and these can be picked up by waveforms. And sometimes it is difficult to differentiate between INS and FMNS when there is especially esotropia, and the waveforms are classical for each type. Classical OCT finding, most common finding is foveal hypoplasia. VEP is important, or may show changes in albinism. And ERG may pick up things like retinal dystrophies very early, even when there is no fundus changes. Typical INS has a very classical history, very early history, no oscillopsia, and it's usually horizontal, and there's associated head posture or a latent component and associated eye diseases. Red flag signs include late onset, no family history, oscillopsia, vertical component which is very prominent of the nystagmus, neurological signs in an unwell child. This calls for neuroimaging. And neuroimaging has to be done in all acquired nystagmus, PAN, all vertical nystagmus like seesaw, downbeating, upbeating nystagmus, which have localizing signs, spasmus nutans, and if the child is having poor vision and disc pallor. Treatment can be non-surgical and surgical. Non-surgical treatment includes optical methods, medications, and Botox. Optical treatments include spectacle corrections of refractive errors. Contact lens is supposed to give tactile feedback and dampen nystagmus. Low vision aids when and where needed. Prisms also to induce convergence or to shift the null position. Medications most commonly said to be used are baclofen, GABA agonists like gabapentin, clonazepam, memantine, and valproate. Brinzolamide is also, topical brinzolamide is supposed also to decrease nystagmus. The aim of surgical treatment is to, when there is a compensatory head position, to shift the null position from eccentric to primary gaze and decrease the intensity of nystagmus and improve fovation time and correct the associated strabismus. Most common and popular surgery is modified Parks-Kestenbaum surgery. And here you shift the eye in the direction of the face turn. And the classical 5, 6, 7, 8 surgery, which usually is done, is recession of the agonist in the side of face turn and resecting the antagonist. And augmentation can be done for head postures greater than 30 degrees. There is surgery mentioned even for head tilt and chin up and down position. For head tilt, you can shift the horizontal muscles vertically or the vertical muscles horizontally. And chin up and down also includes recession and resection of the corresponding vertical muscles. Nystagmus, when it is associated with strabismus, you correct the nystagmus or the head posture in the fixing eye and the strabismus, rest of the strabismus in the corrected eye, in the other eye, sorry. And face turn with head tilt can also be dealt surgically. Other surgery suggested is anterior tenotomy with reattachment without any recess and resect, inducing artificial divergence and maximal recession of the horizontal recti. To summarize, first and foremost, you have to see whether the child needs neuroimaging. If it has to be done, it has to be done. Then treat simple sensory issues like congenital cataract or glaucoma, which will go a long way in improving vision. And then decrease nystagmus, which will, with nystagmus surgery, which will improve vision. Thank you.
Thank you, Dr. Anju, for an exhaustive presentation on nystagmus. Very well done.
Thank you.